Good morning, everyone. My name is Alicia Minns. I'm the Fellowship Director at UCSD in San Diego, and I'm going to be talking to you today about radiation poisoning. So my outline of the talk is I'm going to go over some history of radiation poisoning. We're going to talk about basic science, stuff that you're going to have to know for your boards. We'll go over the clinical presentation of acute radiation syndrome, how to diagnose it, and treatment. So just in terms of types of radiation emergencies, typically when we think about radiation poisoning, we all think about a nuclear emergency. This is where you have an explosion of a nuclear weapon or device, and that produces something called fallout, where the radiation, exposure to radiation is spread over a large surface area. But there are several other types of devices or ways that people can get radiation poisoning or exposure to radiation. There's something called a dirty bomb, which is also called a radiological dispersal device. And that's where you have a mix of explosives that are mixed with some sort of radioactive material. It will create atomic blast, but doesn't have the same degree of fallout as a nuclear emergency. There's also a nuclear power plant accident, and there's several historical examples of this, such as Chernobyl. And that's where there's an accident that releases radiation over an area. These nuclear power plants are actually very heavily monitored by something called the NRC, a regulatory body that I'll talk about in a little bit. And so luckily, nuclear power plant accidents are not that common. There's also radiological exposure devices where you have a hidden sealed source, and so someone or multiple people get exposed without their knowledge. There's transportation accidents that can occur. This is where shipments will have a spill or something like that. That being said, shipments are actually required to have documentation and labeling that identify cargo as radioactive, and any sort of transportation of any radiological material is very highly regulated by the Department of Transportation. So luckily, these don't occur very often either. And then, of course, we have our occupational accidents. This is where you would have like a radiation source, like a spill of nuclear medicine in a hospital. Typically, these are recognized right away, and luckily, most people don't get significant exposures with occupational accidents. So let's just go over some basic principles of radiation. So radiation is basically defined as energy that is sent out in waves in the form of waves and particles. In 1900, Marie Curie discovered that unstable nuclei decay or transform into more stable nuclei. These are called daughters, via the emission of particles of energy, and this whole process is called radioactive decay. Now, radioactive decay occurs mainly through 5 different mechanisms, but we're going to really just focus on emission of gamma rays, alpha particles, and beta particles. Now, each radioisotope has a decay signature, meaning the emitted particles from a particular isotope have known energies. So the identification of a radiation source is possible. Now, we talk about half-lives. Half-life is the time it takes for an isotope to lose half of its radioactivity. Now, this can be seconds to billions of years. And you can see on this chart here, different isotopes will have very significant differences in their half-life. For example, polonium-210 has a half-life of 128 days. Polonium-218 has a half-life of 3 minutes. Isotope is just terminology for a nuclide with the same number of protons. This would be like uranium-235 and uranium-238. Now, radioisotopes are isotopes that are radioactive. Another example is iodine. It has 4 isotopes. All of them are radioactive except for 127. So X-rays and gamma rays are high-energy photons that are really only distinguishable from their source. Gamma rays are emitted from unstable atomic nuclei via radioactive decay. X-rays are from other processes that occur outside the nucleus. For example, an X-ray machine accelerates electrons through large voltage, colliding them into a metal target, and when they decelerate, they make X-rays. X-rays and gamma rays have high energy and can penetrate several feet of insulating concrete, and this is what's depicted on the picture to the right. Beta particles are electrons that are emitted during beta decay. They have less energy than gamma radiation, but still pass through about a centimeter into human skin. And then alpha particles are helium nuclei, so they are 2 protons and 2 neutrons. These can be shielded by skin, paper, clothing, and they are heavy particles which essentially need to be incorporated into your body to cause health effects. And we'll talk about that shortly. So what's the difference between ionizing and non-ionizing radiation? Ionizing radiation refers to any radiation with sufficient energy to disrupt an atom or molecule that it impacts. Chemical bonds can be altered, free radicals are formed, and then you basically get tissue damage. Hydroxyl free radicals are formed by ionizing water, and these are actually responsible for the lesions that occur in radiation toxicity. Now, there is a specific terminology that you should be familiar with called linear energy transfer, and this is the energy loss per unit length of particle, and this is expressed in kiloelectron volts per micrometer. Heavy particles, such as alpha particles, are referred to high LET radiation. X-rays, gamma rays, and fast electrons are low LET radiation. Now, for a source of radiation to pose a threat to tissue, the ionizing particle must be placed in close proximity to vital components of the tissue to inflict damage. So again, our alpha particles are very big, they have less tissue penetration, and they need to be incorporated into your body to cause damage. Beta emitters have similar limited tissue penetration and are usually incorporated before damage can occur, although large external exposures can cause cutaneous injury. Now, in general, non-ionizing radiation consists of relatively low energy photons, and it's used safely in stuff like cell phones, TV signal transmission, radar, microwaves, metal detectors, etc. Now, although these are all considered radiation and that they are all energies released from a source, these photons lack the necessary energy required to cause ionization and cellular damage. So this is something that we all need to know specifically for our boards, and it gets a little bit confusing when we talk about units of measure because there's several different terminologies that people use. So I'm going to hopefully simplify it for you, and you can refer to these charts as a source for studying. So in general, the amount of radiation to which anything is exposed is given in units called Roentgens. Now, this term is actually now considered obsolete. It's a unit for measuring the quantity of gamma or X-ray radiation by measuring the amount of ionization in air. For example, if you're standing close to an X-ray machine, you're exposed to a certain number of Roentgens of X-rays. Now, the key to understanding the different definitions is that not all radiation to which someone is exposed poses a risk for cellular damage. Much of the radiation passes through the body and causes no harm. Only a fraction of that is absorbed by the tissue and actually has a chance of causing damage. The International System unit that describes the absorbed radiation is the gray, which has replaced the rad, which stands for radiation absorbed dose. And you can see 1 gray equals 100 rad. So gray is the terminology that now we typically use. The effective dose is the risk of biological damage regardless of the type of radiation. And this is given in sieverts, which has replaced the rem, Roentgen equivalent man. So 1 sievert equals 100 rem. And again, we use sievert. This is a calculation called dosimetry. And when we talk about the effective dose, it's based on dosimetry, which actually takes into account several different factors, such as the type of exposure, the particle, and the particles involved. In 1910, the Curie became the unit for describing the amount of radioactivity in a source, and this has replaced the becquerel. So you can see this is pretty much all depicted in your chart to the left. I put a chart to the right, which sort of gives just a general example to help with understanding. So the number of falling apples from a tree can be compared to the becquerel, which is the number of disintegrations per second. The number of apples that hit the sleeper underneath the tree can be compared to the gray, and the effect that it has on the body, based on the size and the weight of the apples, can be compared to the sievert, which is the effective dose. So just some more definitions. An object is irradiated when it's been exposed to ionizing radiation. The risk of tissue damage depends on the total amount of radiation and the tissue type, because different tissue types have their own intrinsic resistance to radiation damage. An irradiated object does not become radioactive itself unless it's exposed to neutrons. So really, if someone's irradiated, it has the person does not pose any other risk to others. Now, the FDA actually approved irradiation of wheat and flour in 1963, which controls bacteria. And irradiation of food does not make the food radioactive. It does not compromise the nutritional quality or taste or the texture or the appearance of the food. Contamination occurs when radioactive substance covers an object. An example would be if a lab worker spills something on their hands, a radionuclide on their hands and clothes, or is a victim of a dirty bomb where the radionuclide is packaged in a conventional explosive and the explosion disperses the radionuclide over the person. Now, typically, the risk of tissue damage is low, assuming the contamination is detected and appropriate decontamination occurs. Incorporation occurs when the radionuclide is taken up by the tissue and enters the body. Now, this is the principle used in many diagnostic and therapeutic medical procedures, like thyroid ablation or a thallium stress test, as well as some historical cases of poisoning. So in terms of sources of radiation, there's a wide variety of natural sources of radiation. Terrestrial sources originate from radionuclides in the Earth's crust. Geographical areas vary depending on the content of these. Now, radon is a noble gas, and this accounts for most of human exposure. This is actually a decay product of uranium and thorium and poses a health risk when it decays in the respiratory tract. The risk of lung cancer is further increased in heavy smokers who expose their lungs to also polonium, a radon daughter naturally found in tobacco smoke. The second largest natural source of radiation is from ingested radionuclides, of which potassium-40 is the most abundant. As you guys also know, there's been a sharp increase in man-made sources of radiation, mainly from our increased use of CTs and nuclear medicine, particularly for cardiology. But radon is probably the most common natural source. So I just want to talk a little bit about depleted uranium. Here in San Diego, the fellows rotate through a VA clinic, and sometimes they get questions about the radiation risk for depleted uranium. So I thought it would be important just to have a slide on that. Depleted uranium refers to uranium with a lower content of the more radioactive 235 isotope. It's used by the military, and what happens is uranium ore is mined, and about 98% of 238 isotope and 1% of the more radioactive isotope is what's mined. And then what happens is a process called enrichment, which then separates the two different isotopes. So 235 can be used as nuclear fuel, and then 238 can be used in munitions. 238 is very dense, and it's used in armor plating and nuclear weapons and also as ammunition. So in general, depleted uranium is less radioactive. There are many studies investigating the link between depleted uranium and the incidence of cancer with pretty much inconsistent results. So just a little bit about exposure limits. The Nuclear Regulatory Commission, NRC, has established standards for protection against radiation. And what they have recommended is all exposures should be kept as low as reasonably possible. Doses to individuals should not exceed limits that are established by the NRC. So their recommendation is that the total dose should not exceed 50 millisieverts per year, and then the dose to the fetus of a pregnant radiation worker may not exceed 5 millisieverts over 9 months and should not exceed 0.5 millisieverts in any month. We can't have a toxicology talk without discussing regulation and reporting. I have to say that this is extremely complicated, and the use of ionizing radiation, radiation sources, and byproducts of nuclear energy are probably among the most heavily regulated processes worldwide, and there are numerous international and national organizations that cooperate internationally. Now, in the United States, the National Council on Radiation Protection and Measurements, which is not a government agency, reviews recommendations from the International Commission on Radiological Protection, and they issue something called a BEER report. BEER stands for Biological Effects of Ionizing Radiation. Now, these have direct standards for ionizing radiation use. Now, for medical imaging standards, recommendations from the NCRP are considered to be guidelines that all radiology departments must comply. The EPA oversees the general area of environmental monitoring of radiation. The FDA regulates design and manufacture of electronic products, including X-ray equipment. And then the NRC regulates medical, academic, and industrial uses of nuclear materials from a nuclear reactor. And then, of course, OSHA is the body that regulates any sort of occupational exposure. So a lot of different players involved. Hopefully this is not something that's typically tested on because it is complicated. So let's just talk about some of the pathophysiology, getting into the more interesting aspects of radiation poisoning. So ionizing radiation causes damage to tissue by either a direct effect or an indirect effect. Direct effects are when particles physically damage the DNA in a cell. High LET radiation, i.e. alpha particles, are more likely to cause direct effects owing to its greater probability of actually interacting with DNA. Now, this can lead to mutation, which can then alter a germline, leading to either neoplasm or cell death. The risk of this is overall low because there's only a small amount of active DNA in a cell, and also DNA can repair itself. Indirect effects are more likely, and these are predominantly caused by low LET radiation, such as X-rays or gamma rays. This is when a high reactive free radicals are formed, leading to cell damage. There's actually something called a bystander effect, and this is where cellular damage of unirradiated cells that neighbor irradiated cells occur, and you have increased chromosomal damage and cell death that's been observed. This is interesting. They've actually done studies where they will take a small beam of alpha particles that will irradiate some cells, and they will look at the unirradiated cells surrounding the area, and these also have cellular damage as well. And then there's a terminology called genomic instability, and that's when a single mutation causes a cascade of further mutations. So genomic instability can be observed in the progeny of irradiated cells that multiply and progeny later. So double-stranded breaks in DNA are the most likely to cause damage. There's something called the radiosensitivity of a cell, and that directly relates to the rate of proliferation and inversely relates to the degree of differentiation of the cell. So thousands of lesions occur every day in the body, and we can repair them. And this is actually the basis for radiation therapy, which takes advantage of the less effective repair mechanisms of tumor cells. There's also some evidence that DNA damage induced by radiation is chemically different than damage that occurs from spontaneous radiation, from like a nuclear bomb. And so, as you guys probably already know, there are some very radiosensitive cells, such as bone marrow cells, the lens of the eye, gonadal cells, lymphocytes, and your GI mucosa. And then there's more, or I should say less radiosensitive cells, such as muscle, connective tissue, bone, and nerve cells. And this actually forms the basis of what we typically see in acute radiation syndrome and what symptoms to expect first, and also how we diagnose it and prognosticate the disease. So there's another concept that's important for you guys to be aware of, and this is the difference between stochastic versus deterministic effects of radiation. So radiation damage has two consequential results. It either kills cells or it causes cancer. Injuries that do not require a threshold limit to cause DNA damage are called stochastic effects of radiation. So theoretically, with stochastic effects, there's no dose of radiation that's too small to have the potential to cause cancer. And this can follow less severe exposures. Deterministic effects of radiation usually follow a large whole body exposure. In terms of cell death, a large number of cells of an organ system must be killed before an effect can become clinically apparent. And this is what you'll see with sort of large-scale Chernobyl types of events. So let's talk about acute radiation syndrome. This was first described in 1946 when victims of Hiroshima and Nagasaki were admitted. And this is when a patient is exposed to massive whole-body irradiation, generally considered to be equal or greater to 1 gray, which is about 160 times the average annual exposure of background radiation. Now, it's often difficult to obtain a reliable estimate of the radiation dose, so it's more practical to focus on the clinical features and their prognostic utility. Acute radiation syndrome involves a sequence of events that varies with the severity of the exposure. Generally, more severe exposures lead to more rapid onset of symptoms and more severe clinical effects. And you can see in the chart phases of radiation therapy where you have the dose, and we'll talk more in detail about the prodromal manifest phase as well as prognosis, but here's a general guide to what you're typically going to see depending on the radiation dose. So there are 4 classic phases of acute radiation syndrome that are described, which begins with the early prodromal stage, and that's typically nausea and vomiting. These symptoms will begin either hours to days after the exposure. The greater the dose, the more rapid onset of symptoms, the longer duration, except if you die. The latent period follows next, where there is an apparent improvement in symptoms and the patient may or appears to maybe have recovered. This duration of this stage is inversely related to the dose and lasts from several days to several weeks. And then the third phase, which is called the manifest phase, usually begins either in the 3rd to 5th week and consists of manifest illness, where symptoms depend on the specific syndrome. And we'll talk about the syndrome shortly. This can last anywhere from hours to months. And then there's the 4th phase, which is the recovery phase, which may take weeks and may take longer, up to years. Now, the timing of these symptoms and the severity of the symptoms is obviously dose-dependent. Those exposed to large doses may experience actually all phases in a few hours prior to a rapid death. So this chart describes the subtypes described with acute radiation injury, and you guys have maybe seen this chart before. These syndromes are not mutually exclusive of one another and actually may overlap as damage progresses. The first and most likely and most common syndrome is the hematopoietic syndrome, which refers to the hematologic changes that occur following exposure to about 1 gray or more. Hemopoietic stem cells are very radiosensitive as opposed to the more mature erythrocytes and platelets. Lymphocytes are very radiosensitive and also die quickly from cell lysis after exposure, with the nadir being about 8 to 30 days after exposure. Platelets are consumed in gingiva and GI hemorrhages. So with the hemopoietic syndrome, the net effect is pancytopenia leading to death from sepsis complicated by hemorrhage. The GI syndrome occurs after an exposure to about 6 gray, and GI mucosa dies, which leads to severe GI symptoms, vomiting, diarrhea, abdominal pain, dehydration, and then ensuing sepsis. And then finally, there's the cerebrovascular syndrome, which occurs after massive doses of radiation, 10 to 20 gray or higher. Typically, symptoms are rapid onset of hyperthermia, seizures, CNS symptoms, and then cardiovascular collapse. Other things can occur as well. Patients can actually get a pneumonitis that occurs 1 to 3 months following a dose of about 6 to 10 gray. And then there's a cutaneous syndrome, which actually refers to local radiation injury to the skin, which can be immediate or occurs years, and it's basically a radiation burn. So determining the dose that someone received is important because it can provide therapy and for prognosis. This is difficult for a number of reasons, such as the absence of a radiation monitoring device, exposure to radiation of mixed forms, such as beta and gamma, and particle shielding of various body parts. Biodosimetry is the terminology, and it's the practice of using physiological, chemical, or biological markers to reconstruct radiation doses to individuals. Now, currently, there's numerous tools available on the internet to assist, including the Biological Assessment Tool, guidelines from International Atomic Energy Agency, and the Radiation Emergency Medical website. Now, in general, key elements to dose estimation include time to onset of vomiting, lymphocyte depletion kinetics, and then chromosomal assays, and we'll go over all of these. So, in terms of estimation of dose, for a single acute external exposure, the dose can be estimated from the interval between the exposure and the onset of vomiting. This is not a perfect way of estimating the dose because some people don't vomit, and then there are people who vomit in response to anxiety and something else like that. But you can see Table 4 is the dose estimation from the time to emesis, and it is a helpful tool in assisting with the prediction. Now, in a patient who receives more than about a half a gray as a single acute exposure, 3 or 4 lymphocyte counts within an 8 to 12 hour of the exposure can provide a quick estimate of the radiation dose. Initial counts establish a baseline, and then subsequent event counts reflect the degree of injury, which can be charted on the Andrews lymphocyte nomogram, which gives you a good idea about the severity of injury. Now, measurement of chromosomal aberrations actually has become the gold standard. This technique analyzes the number of dicentric chromosomes that occur following a whole body radiation. Now, when DNA breaks, it causes sticky ends, which then recombine end to end. And in metaphase, these appear as a single chromosome that has 2 centromeres called a dicentric chromosome. The number of dicentrics in lymphocytes correlates reliably with the dose of radiation. There are several limitations to this assay. Mainly, it needs to be done in a timely manner because lymphocytes migrate into tissue during cell death. There's also, I believe, a couple-day turnaround time from when you send the test to when you actually get the results back. There are several other methods of chromosome analysis that may be better but are not widely available. But this still is considered the gold standard for measuring radiation dose. So in terms of general management, the initial management depends on a number of factors, mainly the amount of radiation involved and the number of people exposed. Internal hospital exposures, such as a spill in nuclear medicine, should be referred to the internal radiation safety officer. With local incidents involving nuclear material, first responders should include a hazmat team, as well as local police and fire departments. Hospitals should involve their RSO, or their radiation safety officer, as part of their primary mission for the U.S. Department of Energy. And then there's the REACT, offers consultation with anyone on a 24-hour basis. And I'll show you the website for that. Now, in a mass casualty, decontamination should occur on-site prior to transportation of victims. Uninjured contaminated patients should be relocated upwind of the incident site. And then usually C or D level protection is required. This is a whole separate chapter in terms of protective equipment in of itself, but I put a quick picture here just to show you what C and D level equipment entails. It's not the full enclosed breathing apparatus that is required for other stuff. So moving on in terms of general management, Per Goldfrank, it is not a medical emergency to have been irradiated or contaminated, as even high irradiated patients take days to die, which is pretty much why standard protocols for trauma or other medical complaints need to be followed, even in a large accident. Ideally, the ED should be divided into clean and dirty areas, where the dirty area is covered with plastic or something else. Now, due to the complex nature of radiation contamination, various consulting services will be involved, and it's helpful to follow an algorithm that takes into account these complicated issues. I by no means want you to memorize this algorithm, but this is the REACT algorithm, which is probably the most referenced algorithm. Important history to obtain from a patient includes the location that they were during the incident, the duration of exposure, the time interval between the exposure when they were actually evaluated, occupation of the victim, and of course whether or not they had a recent nuclear medicine procedure. So in terms of initial management, initial lab testing should include a baseline CBC with differential, and additional samples should be sent in a heparinized tube for the cytogenetics. A serum amylase can be sent, which is actually increased from salivary gland inflammation and degeneration, and then you can start a 24-hour urine collection. Nasal swabs, emesis, stool should all be collected for radiological monitoring, and for anyone who has persistent vomiting or fever/hyperthermia, a CBC should be obtained every 4 to 6 hours. If surgery is needed, it should be performed immediately because of expected impaired wound healing that will come later. So decontamination, those who are not decontaminated pre-hospital should be decontaminated in the ED. Clothing should be cut, not torn, and removed clothing should be bagged and removed from the ED to a designated spot determined by the radiation safety officer. These are all pictures that I show you of portable dosimeters that can be used before and after decontamination. So patients should be gently washed with soap and water, starting with the hair. Wounds should be gently irrigated, no vigorous scrubbing or shaving. Patients should blow their nose to get everything out of their nose. And ideally, all irradiated or irrigated fluids should be collected for analysis. This sort of goes without saying, but people should not eat, drink, or smoke at the site of a decontamination. So exposure to radiation leads to a complex clinical picture. So establishment of guidance in the form of a response category can clarify the disposition and plan. So following exposure, there are several criteria that allow for the assessment of a grade of injury, and then this grade will suggest a certain level of care as well as specific treatments, such as whether or not to give blood products, whether or not to give colony-stimulating factors, bone marrow transplant, etc. Now, this is actually Table 134/4 in Goldfrank, which was adapted from several references and is actually really good at showing you what I mean in terms of establishing a response category. But I'll give you an example. If someone comes in and they have a severe headache, they're vomiting 6 to 10 times a day, they have a lymphocyte count of 0.5, platelets at 25, and frequent bloody bowel movements, they are a Category 3, which per guidelines means they need ICU level of care, blood products, and colony-stimulating factor. There's actually a tool on the Radiation Emergency Medicine Management site, and I put the website below, which is really helpful, and I'll show you briefly how that works. So, oh, this is interesting. Okay. I'm going to actually skip through this because it's not showing. I'll just show you briefly. If you go to the website, I have several different buttons to click, which takes you through it. But if you go to the website I'd mentioned, there is a radiation nuclear accident, and it's basically a tree with several different options that you can click on. The one that I'm clicking on here is signs and symptoms of acute radiation syndrome, which is actually hidden under this box. So if you click on it, another box will pop up, which is this one, that shows you targeted physical examination following a nuclear detonation. And then here, you can estimate the dose. And so I have clicked lymphocyte depletion kinetics, And if you click on that, another box will show up, which actually you can put in the time, the exposure, as well as the blood counts. And hidden behind this box, you press enter, and it actually gives you a calculated radiation dose. And then you can begin assessment and management, and if you have any questions about what the different syndromes are and what to look for, you actually can click on one of these boxes, and we'll actually allow you to input different data, and you can click View Treatments to Consider, View Response Category, or Start Over. So this is all on this website that I showed you, and it's fun to actually just go through and put in different scenarios just to see if you're ever in this situation. It's a quick, easy guide to determine help you determine how sick is this person and what type of care are they going to need. Especially helpful if you're in a community setting and you're thinking about transferring a patient to a higher level of care. So just moving on to medical management. So good supportive care is, obviously with most things in toxicology is paramount, as patients who die do so from fluid loss, bleeding, or infection. Vomiting is actually thought to occur from serotonin release from damaged gut tissue. So the 5-HT3 antagonists like ondansetron are the most effective. Now, emesis will usually resolve after about 3 days. There are some experimental studies showing that probiotics actually can be helpful. And then prevention of infection should include reverse isolation, and then consider any sort of prophylactic antibiotic, antifungal, and antiviral for anyone who becomes neutropenic, even without a fever. So use of cytokine therapy is based on demonstrated neutrophil recovery in cancer patients. In several animal studies of radiation exposure, which not only demonstrate neutrophil recovery, but also a survival advantage. Now, the best outcomes occur if colony-stimulating factors or cytokine therapy is started within 24 hours after radiation. So the recommendation is actually to give it to anyone as soon as possible after exposure to greater than 3 gray, and then certainly a lower threshold in the extremes of age. Blood products should be administered to anyone with significant blood loss or those who experience aplasia, which typically occurs several weeks after exposure. Ironically, the blood should be leukocyte-reduced, irradiated blood to prevent graft-versus-host disease. And then stem cell transplantation can be considered, but the use of this is actually complicated because those suffering mainly from the hematopoietic syndrome can actually survive following large exposures and supportive care. Those with greater doses, say greater than 10 gray, typically have other concurrent injuries, such as severe burns or ARDS, which would limit the use of stem cell transplantation. So historically, survival is inversely proportional to the radiation dose absorbed. Historically, the LD50 at 60 days was about 3.5 gray. Now this has increased to about 6 to 7 gray with better care, blood products, antibiotics, et cetera. Dose of 20 gray or more is considered lethal, and many feel that greater than 10 gray should be given just supportive care and comfort care, as survival is considered unlikely. Interestingly, dead bodies should not be cremated because the nuclear material can then get redistributed after that. So in an interactive talk, I would ask you who this guy is, but since it's not, I'll tell you, this is Alexander Litvinenko. And I wanted to go through a couple of interesting examples just to highlight some of the concepts that we've already discussed. He died of acute radiation syndrome from polonium. Now, Alexander Litvinenko was an officer of the Russian Secret Service who in 2000 was granted asylum in the United Kingdom, and it is said by his widow to actually have begun working as a consultant for the British intelligence services. On November 1, 2006, Mr. Litvinenko fell ill and was admitted to a hospital. And his illness was later attributed to poisoning with polonium-210, since substantial amounts of this highly toxic radionuclide were found in his body. An inquest into his death was opened and adjourned in 2006 due to outstanding criminal proceedings, and this inquest was subsequently resumed when it became clear that the 2 men suspected of his murder could not be extradited from Russia. So let's go through his case. So on November 3rd, 2006, there was a 43-year-old guy named Edwin Carter who presented to a hospital in London complaining about abdominal pain, vomiting, and diarrhea, which started on November 1, so 2 days prior. And that was designated as day 1 following the chronology. Now, on exam, he appeared dehydrated, he was afebrile, he had a normal blood pressure, normal pulse, he had some epigastric tenderness, and in view of his profuse nature of his diarrhea, he was given a provisional diagnosis of gastroenteritis, possibly of infective origin, and he was admitted and started on fluids and Cipro IV. Labs showed an elevated BUN and creatinine, he had a leukocytosis, all suggesting dehydration and possibly gastroenteritis. On day 7, his stool grew out C. diff, and when this was discussed with him, he revealed his previous identity and suggested that maybe he had been poisoned, and he thought maybe he had been poisoned with C. diff. And at that time, he disclosed that he had defected from the prior Russian Secret Service, and on the day that he got sick, he had met with prior KGB agents. So here's a chronology of his illness. On day 9, he started to get neutropenic and thrombocytopenic, and then he spiked a temperature and was started on antibiotics. And then after he developed alopecia and mucositis, him and his wife raised the concern of being poisoned again, and so their toxicology unit was consulted and a heavy metal screen was sent. They also used a standard Geiger counter, which revealed only background levels. On day 16, his heavy metal screen came back with slightly elevated levels of thallium, which he was concerned about, but the treatment team didn't think so because he did not have a peripheral neuropathy, which is a key feature for thallium. Regardless, they said they started him on Prussian blue. So he started to deteriorate, and they started to look for a radiotoxin. This is actually on the left is a picture of his blood smear on a radiograph, which basically shows that the film opacified when just exposed to his blood, not covered by a glass slide. They sent out his urine for spectrometric analysis, which showed the presence of something that was 825 becquerel per ml, which is consistent with polonium. Unfortunately, he deteriorated, and postmortem analysis showed polonium retention in all of his organs, with the highest in his liver and kidney with massive accumulated doses of radiation. And this all came back just prior to his death. And you can see here, this is in gray, the total dose, 140 gray to his kidneys, just huge, massive amounts of radiation that he was exposed to. So I just want to talk briefly about polonium. It's a naturally occurring element that was discovered in the late 1800s by Marie Curie, and it decays to stable lead by emitting one alpha particle. So humans are constantly exposed to polonium, which occurs at low concentrations in the environment as part of the uranium decay chain. However, the annual intake from natural sources is about 10 to the 8th times less than what this patient got exposed to. It's actually used, polonium is used for a variety of industrial processes and as a power supply in small satellites, but its manufacture actually requires very sophisticated equipment. Therefore, it's not widely available, but is an effective poison. It's water soluble, it's colorless, it's readily absorbed across biological membranes, becoming widely distributed in organs and tissues where alpha particles deliver a large amount of energy to surrounding cells, causing cell death and damage. It's interesting, the early symptoms of polonium are pretty indistinguishable from those of a wide range of chemical toxins. Therefore, the diagnosis can be delayed and even missed without a high index of suspicion. Now, it can be transported easily and safely without detection because it's a high-energy alpha particle, has short range, and it's blocked by a thin barrier such as the skin. So this is why, in this situation, the Geiger counter was unable to detect the radiation emitted from polonium. And so you have to use a specific test to actually detect it in bodily fluids. But this is actually not readily available in most facilities. So the next incident I wanted to talk about was the Goiânia incident in Brazil. Now, in September of 1987, 2 laborers collected a canister from an abandoned radiotherapy institute. The capsule was opened and divided at a scrapyard and then transported throughout the city. What was inside this capsule was cesium, 137, which was very luminescent and attractive, so several people, including children, handled the material and even used it as like a face paint. And it actually took 2 weeks for the consequences to be realized. I just wanted to show you a picture. This is, if you ever PubMed the Goanna incident, it's very interesting how they sort of manually drew out how everything was dispersed. And these are just pictures of how these 2 laborers brought it to a scrapyard and how eventually over several weeks this radioactive material was distributed to this huge town and all the different people who got exposed. So at least 244 people were known to be exposed to cesium. 49 were ill with alopecia, diarrhea, and a rash, and then 21 were critically ill with infections and spontaneous hemorrhages. There were 4 deaths. Unfortunately, one of them was a child, the daughter of one of the initial laborers, who passed away from acute radiation syndrome. And so I just thought this was an interesting historical example of radiation poisoning. And if you ever read about it, it's just interesting how they detailed it and how they investigated it. There's also Chernobyl, which is another large historical nuclear power plant where, accident where basically every fail-safe measure failed, and there was a large exposure and large number of deaths that you guys should be familiar with for your boards. So just in summary, things that I think are important to remember are knowing your units, and hopefully I gave you some tools just to reference if you're ever wanting something to look at to study. Know the difference between deterministic and stochastic, and in terms of diagnosis, just remember that the dicentric chromosomes are the gold standard, but there's different tools such as lymphocyte depletion kinetics, onset of vomiting, that help as well to determine the dose and how to diagnose, and there are several online tools that can be used to assist you if you're ever in a situation where you need to, where you're actually managing a patient. So I just want to say thank you for giving me this opportunity to talk about radiation poisoning. I have to say I don't have much clinical experience with it, although I do find the topic very interesting, and it is something that we need to be familiar with as toxicologists. So hopefully you have increased familiarity with it, and good luck. Thank you.